one of the most prescribed heart medications in history, a drug so trusted that millions of people still take it every day without a prescription, without a diagnosis, without ever asking a doctor, and new science said, most of them, it is doing more harm than good. This is the story of aspirin, how it went from medical miracle to one of the most controversial reversals in modern cardiology, and why most people who take it right now probably should not be. Stay until the end, because the last part about who actually benefits is the one that will change how you think about this pill forever. Aspirin has been around longer than modern medicine itself. Around 400 BC, Hippocrates, the father of medicine, was already recommending that patients chew willow bark to relieve pain and fever. He did not know why it worked. He just knew it did. More than 2,000 years later, scientists identified the active compound, salicylic acid, in 1897. A chemist at Bayer named Felix Hoffmann synthesized a more tolerable version, acetylsalicylic acid, and aspirin was born. It became the first mass-produced pharmaceutical drug in history, sold in pharmacies across the world before World War I had even started. For most of the 20th century, aspirin was the definition of a wonder drug. It relieved pain, reduced fever, fought inflammation, and most importantly for this story, it seemed to prevent heart attacks. An aspirin a day keeps the heart attack away became one of the most repeated pieces of medical folk wisdom in the Western world. Doctors passed it along. Families repeated it at dinner tables. It became part of the cultural furniture. And for decades, the medicine was right there with the culture. Guidelines routinely recommended low-dose aspirin for adults over 50 as preventive medicine. Here is what changed. To understand why the science reversed so dramatically, first need to understand what aspirin actually does inside your body. Your blood contains tiny cells called platelets. Think of them as small bricks designed to plug leaks. When you cut yourself, platelets rush to the wound, become sticky, pile on top of each other, and form a clot to stop the bleeding. That process is essential. Without it, a small cut could kill you. The problem arises when someone has fatty plaque building up inside the arteries of the heart. Those plaques can rupture when they do. Platelets respond the same way they always do. They rush in, become sticky, and try to form a clot, except now they are forming that clot inside a coronary artery. The artery narrows, blood flow drops. The heart muscle does not get the oxygen it needs. That is a heart attack. Aspirin interrupts this process by blocking an enzyme called cyclooxygenase. When cyclooxygenase is blocked, the body cannot produce thromboxane A2, the chemical signal that tells platelets to become sticky. Less thromboxane, less stickiness, less clotting. And here's what makes aspirin unusual. This effect is permanent. Aspirin does not temporarily suppress platelet function. It permanently disables every platelet it touches. A platelet affected by aspirin stays non-functional for the rest of its life, which is about 10 days. This is why the dosing matters. Your body produces about 10% new platelets every day. So to keep clotting suppressed, you need a dose of aspirin every single day, miss a day, and that 10% of fresh, fully functional, sticky platelets is already there enough to form a clot in the right conditions. So the mechanism is real. The logic is sound. Aspirin genuinely does what it is supposed to do. Then why did the guidelines change? In 2018, 3 landmark clinical trials published their results within months of each other together. They enrolled more than 47,000 patients and asked one specific question. Does aspirin prevent heart attacks and strokes in people who have never had either? The first was Aspirin, the aspirin in reducing events in the elderly trial. It followed more than 19,000 people aged 70 and older across the United States and Australia who had no history of heart disease. They were randomly assigned to take either low-dose aspirin or a placebo every day for nearly 5 years. The result: aspirin did not reduce cardiovascular events. It did not reduce deaths from heart disease. It did not reduce overall mortality. What it did do was significantly increase the rate of major bleeding, internal bleeding from the stomach, intestinal tract, and brain. The second was ARRIVE, the aspirin to reduce risk of initial vascular events trial. This study focused on people with moderate cardiovascular risk who had never had a heart attack or stroke. Again, aspirin did not reduce the primary cardiovascular endpoint, and again, it increased the rate of gastrointestinal bleeding. The third was ASCEND, a study of cardiovascular events in diabetic patients without prior cardiovascular disease. Aspirin reduced cardiovascular events slightly, but the reduction was almost exactly canceled out by an equal increase in serious bleeding. 3 studies, 3 populations, 1 conclusion. People who have never had a heart attack or stroke. The balance between benefit and harm is unfavorable. Let us put that in numbers that actually mean something. Take 1,000 healthy adults and have them all take low-dose aspirin for several years. The research suggests aspirin will prevent approximately 4 serious cardiovascular events in that group. Heart attacks, strokes, 4 prevented. In those same 1,000 people, aspirin will cause approximately 5 serious bleeding events. Stomach bleeds, intestinal hemorrhages, brain bleeds, 4 saved, 5 harmed. The math does not work, and the number that should land hardest. In primary prevention populations, aspirin did not reduce total mortality, People did not live longer, they did not die less. They just had different risks redistributed between them, with the bleeding side winning. This is the reversal that most people have not heard about. Now here is what is critical, because this is where 90% of the confusion lives. There are two completely different situations when it comes to aspirin, and they have opposite answers. The first situation is called secondary prevention. This is for people who have already had a cardiovascular event, a confirmed heart attack, an ischemic stroke, a stent placed in a coronary artery, a bypass surgery, or a documented blockage of 50% or more in a major artery. For these people, there is no debate. Aspirin is, in most cases, mandatory for life. Here is why. Once you have had a cardiovascular event, your risk of a second one is dramatically higher. Your arteries have already shown they can form dangerous clots. The benefit of keeping platelets suppressed is enormous, far larger than the bleeding risk. Stopping aspirin in this group without medical guidance can be genuinely dangerous. If you have a stent, if you have had a bypass, if you have had a heart attack, do not stop your aspirin without talking to your cardiologist. That is not the group this story is about. The second situation is primary prevention. This is the group at the center of the reversal. These are people who are considered generally healthy, no prior heart attack, no prior stroke, no stent, who want to take aspirin as insurance, just in case. And this is where the science changed. For adults over 60, current guidelines from the American Heart Association, the American College of Cardiology, the U.S. Preventive Services Task Force all now recommend against initiating aspirin for primary prevention. The bleeding risk in older adults is too high. Blood vessels become more fragile with age. A bleed that would be manageable at 40 can be catastrophic at 70. For adults between 40 and 59 with a cardiovascular risk of 10% or higher over the next 10 years. This is where the decision is individualized. A doctor needs to calculate your actual risk, weigh it against your bleeding risk, and make a decision together with you. It is not a blanket recommendation in either direction. The risk calculation uses tools like the Prevent Calculator from the American Heart Association. It takes your age, sex, blood pressure, cholesterol, smoking status, diabetes status, and other parameters to generate a 10-year cardiovascular risk score. Below 5%, aspirin is likely not indicated. Above 10% with no elevated bleeding risk. The conversation is worth having with your doctor between 5 and 10. Careful, individualized assessment. For diabetic patients specifically, a group that was once routinely prescribed aspirin, current guidance has also shifted. Unless there are additional high-risk features, the recommendation is now to avoid aspirin as a default. Well-controlled diabetes alone is not enough to justify the bleeding risk. Now let us talk about what aspirin can actually do to you if you are in the wrong group. The most common risk is gastrointestinal, even at low doses. 81 to 100 milligrams. Aspirin irritates the lining of the stomach and small intestine. This can lead to gastritis, peptic ulcers, and chronic blood loss significant enough to cause iron deficiency anemia over time. The bleeding can be slow and silent for months before it is detected. The more dramatic risk is cerebral hemorrhage. This is a brain bleed, a stroke caused not by a clot, but by a blood vessel rupturing while the blood cannot clot properly. Imagine this scenario. One takes aspirin daily without knowing they have poorly controlled high blood pressure spikes. A small vessel in the brain gives way. In a normal situation, that might be a minor, self-limiting bleed with aspirin suppressing platelet function. The bleed does not stop easily. What could have been manageable becomes life-threatening. The third risk is drug interaction, and this one is widely underestimated. If you regularly take ibuprofen or diclofenac for back pain or arthritis, and you also take daily aspirin, you are compounding the gastrointestinal risk dramatically. Both drugs irritate the stomach lining through related but distinct mechanisms. Taking both regularly can create the conditions for a serious bleed, even in people who have no other risk factors. On the question of dose, science is clear that any dose between 75 and 100 milligrams is sufficient to inhibit nearly 100% of platelet function. A higher dose, like the 325 or 500 milligram tablets used for pain, does not provide more cardiovascular protection. It only adds more risk. And one more error worth addressing directly. Some people, trying to be cautious, take aspirin every other day instead of every day, thinking that skipping a day reduces the cumulative risk. This is wrong, and in secondary prevention patients it can be dangerous. Remember, your body produces 10% new platelets every day. Those new platelets are fully functional and fully sticky. If you skip a day, you have a fresh cohort of clot-ready platelets circulating in your blood. In someone with significant coronary plaque, that is enough to trigger an event. If your cardiologist has prescribed daily aspirin, the dose is daily for a reason. Consistency is the entire point of the mechanism. So where does that leave us? Aspirin is not a villain. It is one of the most important drugs ever developed. For the right person, someone who has had a heart attack, who has a stent, who has documented coronary disease, aspirin may be the single most important medication they take every day. but for the person who started taking it because they read something online, because their neighbor told them it was good for the heart, because they assumed more prevention is always better, the evidence now says stop. Not because aspirin stopped working, but because the assumption that everyone benefits was never based on the right evidence. And now we have the right evidence. The pill is not the problem. The assumption that everyone needs it is. If you're taking aspirin right now and no doctor ever prescribed it to you, this is your moment to bring it up at your next appointment, not to panic, not to stop without guidance, just to ask the question, do I actually need this? And if your doctor prescribed it because you have had a cardiac event, do not touch that bottle. The story here is not for you. This is how medicine works at its best, not a drug that works for everyone, but a drug that works precisely. For the people who actually need it, this video is for educational purposes only. It is not medical advice and does not replace a consultation with your doctor or cardiologist. Do not start or stop aspirin or any medication. Based on this video, if you are currently taking aspirin that was prescribed by a physician, do not stop without speaking to that physician first. If you are taking it without a prescription, bring the question to a qualified medical professional who can assess your individual cardiovascular risk. Every decision about aspirin must be individualized.